Hi everyone, welcome back to my YouTube channel. In today's video, I will be sharing with you MedPAC's recommendations to Congress on the Medicare fee-for-service payment policy in 2023 for acute care hospital, physician and other health professional, ambulatory surgical center, outpatient dialysis facility, skilled nursing facility, home health agency, inpatient rehabilitation facility, long-term care hospital, and hospice services. Let's get started. Hospital, inpatient, and outpatient services. MedPAC stated that their payment adequacy indicators are mixed, but generally positive, and they anticipate changes caused by the public health emergency to be temporary, other than potentially increased wage rates, which should be accounted for under the current law annual updates to the hospital market basket. Given these factors, the Commission recommends that the Congress maintain current law inpatient prospective payment system and outpatient prospective payment system updates in 2023. The final update for 2023 will not be set until summer of 2022, but CMS's third quarter 2021 projections of the market basket and productivity and the additional statutory increase to inpatient prospective payment system payments would result in the inpatient prospective payment system base payment rate increasing by 2.5% and the outpatient prospective payment system base payment rate increasing by 2%. The Commission anticipates that this recommendation will be enough to maintain beneficiaries' access to hospital inpatient and outpatient care and keep inpatient and outpatient prospective payment system payment rates close to the cost of delivering high-quality care efficiently. Changes to the low-volume hospital payment adjustment. The Balanced Budget Act of 2018 mandated that hospitals with fewer than 3,800 all-payer inpatient stays be eligible for the low-volume hospital or LVH adjustment instead of hospitals with fewer than 1,600 Medicare stays as mandated by the Affordable Care Act of 2010 or ACA. However, the Balanced Budget Act of 2018 kept other aspects of the Affordable Care Act of 2010 changes to low-volume hospital policy, including specifying the exact adjustment instead of having the Secretary of the Department of Health and Human Services determine an empirically justified adjustment and the isolation requirement of fewer than 15 miles from the nearest inpatient prospective payment system hospital. The Balanced Budget Act of 2018 requirement that low-volume hospital eligibility be based on all-payer volume and not Medicare volume is consistent with the Commission's prior recommendation, and low-volume hospital policy will become more consistent with their prior recommendation beginning in 2023 when CMS's authority to determine an empirically justified low-volume hospital adjustment is restored. Still, concerns remain that the policy is not well targeted to isolated hospitals and is duplicative for the majority of low-volume hospitals that receive cost-based payments through their designation as a sole community or Medicare-dependent hospital. Physician and other health professional services. The Medicare Access and CHIP Reauthorization Act of 2015 mandates no update for clinicians for 2023. However, clinicians are eligible for annual performance-based payment adjustments through Medicare's merit-based incentive payment system, or they can receive an annual bonus worth 5% of their Medicare professional services payments if they participate in advanced alternative payment models. The Commission's analysis suggests that Medicare's aggregate payments for clinician services are adequate. Although clinicians have experienced declines in their Medicare service volume and revenue due to the pandemic, the Congress has provided tens of billions of dollars in relief funds to clinicians, and MedPAC expects volume and revenue to rebound to pre-pandemic levels or higher by 2023. Therefore, the Commission recommends that for calendar year 2023, the Congress should update the 2022 Medicare base payment rate for physician and other health professional services by the amount determined under current law. Before the coronavirus public health emergency, CMS paid for telehealth services under the physician fee schedule only if the services were provided using an interactive telecommunication system that included two-way audio and video communication technology. During the public health emergency, however, CMS has waived this requirement for certain services. But Medicare claims do not always indicate whether a telehealth service was delivered by an audio-only interaction or an audio-video interaction. Consequently, CMS and others are unable to use claims data to assess the impact of many audio-only telehealth services on access, quality, and cost. Therefore, the Commission recommends that CMS require clinicians to use a claims modifier to identify all audio-only telehealth services like the agency has done for audio-only telehealth services for mental health conditions and substance use disorders. This recommendation applies whether Medicare is covering these services temporarily or permanently. Ambulatory surgical center services. According to MedPAC, cost data would support more informed decisions about updating ambulatory surgical center payment rates and identifying an appropriate input price index for ambulatory surgical centers. Therefore, the Commission continues to recommend that the Secretary of Health and Human Services collect cost data for ambulatory surgical centers without further delay. Considering the available evidence of payment adequacy, the Commission recommends that for calendar year 2023, the Congress eliminate the update to the 2022 Medicare conversion factor for ambulatory surgical centers. Outpatient dialysis services. Under current law, the Medicare fee-for-service-based payment rate for dialysis services is projected to increase by 1.2%. Given that most of MedPAC's indicators of payment adequacy are positive for 2023, the Commission recommends that the Congress update the calendar year 2023 end-stage renal disease PPS base rate by the amount determined under current law. Skilled nursing facility services. Considering MedPAC's payment adequacy indicators, the Commission recommends that for fiscal year 2023, the Congress should reduce the 2022 Medicare-based payment rates for skilled nursing facilities by 5%. While the effects of the pandemic on beneficiaries and nursing home staff have been devastating, the combination of federal policies and the implementation of the new case mix system resulted in improved financial performance for skilled nursing facilities under Medicare. The high level of Medicare's payments indicates that a reduction to payments is needed to more closely align aggregate payments to aggregate costs. Home health care services. MedPAC stated that Medicare beneficiaries often prefer to receive care at home instead of in institutional settings, and home health care can be provided at lower cost than institutional care. However, Medicare's payments for home health services are too high, and these access payments diminish the service's value as a substitute for more costly services. Based on these findings, for 2023, the Commission recommends reducing the 2022 home health PPS-based payment rate by 5%. According to MedPAC, the lack of detailed information on the use of telehealth in 2020 impairs their ability to assess the impact of the PDGM and the public health emergency. As the use of telehealth in home health care grows, the lack of information about telehealth visits could also compromise CMS's ability to accurately set payments under the home health PPS. The Commission therefore recommends that the Secretary require home health agencies to report the provision of telehealth during home health care on Medicare claims like they already report for in-person visits and other home health care services. Mandated report assessing the impact of the PDGM on home health care in 2020. MedPAC also reported on the effects of the changes to the home health PPS as mandated by the Balanced Budget Act of 2018. The mandated changes included shortening the unit of payment under the PPS from 60 days to 30 days and eliminating the number of in-person therapy visits provided in a home health episode as a factor in the payment system. CMS implemented these changes on January 1st of 2020 under a new case mix system called the PDGM. The Commission is required to assess the impact of the changes on cost, quality, and other behavioral responses by home health agencies. Assessing the initial impact of the PDGM on home health care in 2020 is confounded by the disruptions associated with the coronavirus public health emergency. The payment adequacy indicators for 2020 point to relative stability for Medicare home health care in the first year of the PDGM. Though the number of 30-day periods and the number of beneficiaries served in 2020 were lower than in 2019, the monthly pattern in home health care volume for 2020 signals that the declines were mostly attributable to the public health emergency and not the PDGM. In addition, the high payment levels under the PDGM in 2020 suggest that home health agencies had adequate reimbursement to provide quality care. Inpatient Rehabilitation Facility Services. Given MedPAC's positive payment adequacy indicators, the Commission recommends that for fiscal year 2023, the fiscal year 2022, inpatient rehabilitation facility base payment rate be reduced by 5%. The Commission anticipates that this recommendation would provide IRFs with sufficient revenues to maintain beneficiaries' access to IRF care and bring IRF prospective payment system payment rates closer to the cost of delivering high-quality care efficiently. Long-term care hospital services. Based on payment adequacy indicators and in the context of ongoing changes to payment policy, the Commission recommends for fiscal year 2023 that the 2022 Medicare base payment rate for LTACs be increased by the market basket minus the applicable productivity adjustment. MedPAC estimates based on CMS's third quarter 2021 projections of the market basket productivity that this recommendation would result in the LTAC base payment rate increasing by 2% in 2023, but that may change because the final update for 2023 will not be set until summer of 2022. This update supports LTACs in their provision of safe and effective care for Medicare beneficiaries meeting the LTAC PPS criteria for payment at the standard LTAC PPS rate. Hospice services. Based on payment adequacy indicators and analysis of the hospice aggregate cap, the Commission recommends that hospice payment rates for 2023 be held at their 2022 levels and that the aggregate cap be wage adjusted and reduced by 20%. In response to the public health emergency, CMS modified the hospice conditions of participation to permit hospice providers to furnish services using telecommunication systems during the public health emergency under certain circumstances. However, hospices are unable to report on the use of telehealth services on Medicare claims, with the exception of social worker phone calls, which have historically been reported on claims. This lack of information has impaired MedPAC's ability to understand the frequency and the role that telehealth has played during the public health emergency. For this reason, the Commission's recommendation is that CMS should require hospice providers to report telehealth visits on Medicare claims. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.